We are presenting a case of male 30 who present to us with sudden onset severe headache, vomiting with bitemporal hemianopia with right-sided complete ophthalmoplegia and ptosis since last 15 days. On MRI, there is pituitary macroadenoma about 3 cm in size. There is heterogeneous signal intensity with area of the hemorrhage on the right superior part of the pituitary region. There is compression of the optic chiasm and extension of this tumor into the right cavernous sinus. And this heterogeneous density with T1 MRI lesion showing hyperintense in the pituitary area and pituitary tumor. It is suggestive of the pituitary hemorrhage that is called pituitary apoplexy. That apoplexy most common because of the hemorrhage in the superior hypophyseal artery. So if question asks which artery is most common artery leading to apoplexy, that is superior hypophyseal artery. And hormonal profile, cortisol, TSH, prolactin, GH are the within normal limits. On visual field charting, there is confirmed bitemporal hemianopia. So diagnosis is it is a pituitary apoplexy secondary to hemorrhage into pituitary macroadenoma presenting with headache bitemporal hemianopia with complete right-sided ophthalmoplegia. So in this case, urgent endoscopic transsphenoidal pituitary surgery was planned. This surgery done by Dr. Kairav Shah, neurosurgeon, and Dr. Sunil Kumar Sharma, ENT surgeon at Rajasthan Hospital, Saibagh. Step of surgery, there are 4 phases of surgery: nasal phase, spinotomy phase, sellar phase, and reconstruction phase. In nasal phase, nostril endoscopic approach was planned and elevation of right-sided nasoseptal flap, or you can say Huddle flap, was done. On second step, there is spinotomy was done. There is bad sphenoid ostium was open and there is cavity in half. You can say bad spinotomy with bilateral posterior ethmoidectomy was done. Third phase is sellar phase. In this phase, there is dura was open carefully and evaluation of hematoma. You can see this hematoma is coming out from this reddish tumor is coming out from the sella. After evacuation of this hematoma, removal of tumor was done by the curate and forceps. In apoplexy cases, the color of dura is always bluish in color, while in normal pituitary tumor cases, color of dura is the white color. Early steroid therapy and urgent decompression are key to preventing permanent deficit of the nerves. This endoscopic transsphenoidal approach offers better visualization, minimal morbidity, and faster recovery compared to microscopic approach. You see, after removing hematoma from this pituitary fossa, you can see real tumor is coming out. That is yellowish color tumor is coming out from the fossa. After removing this tumor and completely clearing the pituitary area or sella, you have to plan for reconstruction. In sellar, internal tumor debulking or central decompression should be done first. Use suction or incurate to aspirate the soft necrotic or hemorrhagic tissue first and create a space within the capsule. After clearing the central part, you have to dissect inferior and posterior tumor. After removing posterior and inferior part of the tumor, you can go lateral tumor extension and tumor removal from the lateral part. Then ultimately you can go for the superior part, decompression the optic chiasm safely. In summary, central core tumor removal, then inferior posterior tumor removal, then lateral tumor removal, then at last superior tumor removal should be done till the arachnoid falls. For lateral and superior extension, you can use angled endoscope 30° or 45° for visualization. Avoid direct cavernous sinus entry unless tumor is soft or extend inside the cavernous sinus. If there is apoplexy or large hematoma like this case, evacuate clot first for the decompression. After decompressing the central part, dissection plane are usually easier because of the apoplexy. Tumor capsule collapse after clot removal automatically into the sella. So, key surgical principles. Central debulking first, periphery last. Never start lateral dissection early because of carotid and cavernous sinus danger. Avoid aggressive superior dissection to avoid the damage of optic nerve. Leave adherent remnant if close to the vital structure like carotid and optic. Always reconstruct the cellar floor properly so that to avoid CSF leak. Last phase of this endoscopic resection is the hemostasis and reconstruction. After achieving the hemostasis all around, then cellar floor reconstruction should be done with the fat, fibrin glue, and nasoseptal flap repositioning. After clearing the central part, you have to remove this superior part. You can see in this case, this superior most part of the tumor is coming. Behind that, you can see the arachnoid is falling. You can see pulsation of the arachnoid behind this tumor. After removing this part of the tumor, this is the superior most part of the tumor. A small part may be removed on the right cavernous side. So last part to be removed from the right cavernous portion of the tumor. After removing this last bit of the right cavernous portion, we will check by the 30-degree endoscope if any tumor is there inside the cavernous sinus. If this arachnoid is falling itself are suggestive of complete tumor removal. You can see pulsation of tumor, and this is the right cavernous part of the tumor which going inside the cavernous. We will remove it. You see F-gel is, we have kept the F-gel to prevent the bleeding on the right cavernous part. You can see almost 3 centimeter size tumor was there inside the pituitary fossa, and this dimension of this tumor is exactly matching the dimension of the MRI, that is about 3 into 3 centimeters is size. This tumor is almost completely removed. After tumor removal, we have to plan for hemostasis and reconstruction. As we are using fat, glue, and this nasoseptal hadal flap for the reconstruction. After applying the fat, we will apply the nasoseptal flap, then mirocell, this F-gel, then mirocell packing. So this repair or complete water or airtight closure should be done for the prevention of the CSF leak. You see I am putting this nasoseptal flap, that is hadar flap, on the fat surface. After that we will put the F-gel and mirocell packing. Thank you so much.